Good evening, and thank you for joining us today. My name is Tudor Borza, and I'm the Director of the Music Prostate Program. I'm excited to kick off our webinar that will explore how we as urologists can optimize the quality of care we provide to patients receiving androgen deprivation therapy. We felt this was an important topic to address given the frequency of ADT use in the management of patients with prostate cancer and the high incidence of side effects associated with this therapy. But before we get into the main topic, I want to provide a brief background on what music is. The Michigan Urological Surgery Improvement Collaborative is a community that partners to improve patients' lives by inspiring high-quality care through data-driven best practices, education, and innovation. We do this by focusing primarily on 3 disease states: prostate cancer, kidney stones, and renal masses. Music is comprised of over 260 urologists representing 46 practices across the state who contribute clinical data to our registry that now has over 135,000 unique cases. We rely on input from our provider members and patient advocates to identify quality gaps and create multifaceted quality improvement interventions with the goal of improving urologic care for patients in Michigan and nationwide. I'm also very excited to share that our music network has expanded beyond the state of Michigan with the addition of urology groups at Montefiore, Mount Sinai, Fox Chase, and the universities of North Carolina, Kentucky, and Florida. These sites share a similar mission to that of music, and we look forward to the growth in our quality improvement efforts that these partnerships provide. With that introduction, we'll turn our attention to the topic for tonight's webinar. With these presentations, our goals are to describe the various settings in which androgen deprivation therapy is used, provide a better understanding of common side effects from this therapy, and review possible interventions that may offset some of those side effects to improve quality of life. Over the next couple of slides, I want to give a sense of the number of men in music that are exposed to androgen deprivation therapy for at least some part of their prostate cancer treatment. When we look at the over 40,000 men with localized prostate cancer, we see that about a third of those men choose external beam radiation therapy as their primary definitive treatment. And we know that many of these men will have radiosensitizing androgen deprivation therapy with a course ranging from between 6 months and 2 years as part of their treatment. We also know that many patients are also treated with ADT as part of secondary treatments. And this is from the literature. When we look at the reported rates, we know that somewhere between 20 and 40% of patients will experience biochemical recurrence following their primary treatment. These figures show population-level incidence of biochemical recurrence following prostatectomy and radiation therapy. For both treatments, we see that many events occur in the first 5 years, with the incidence highly correlated with cancer risk at the time of initial treatment. And we know that when treatment is given, ADT is a mainstay in the salvage setting. So what does this look like in music? This figure shows the rate of persistently positive PSA for the 25 or so thousand patients treated with prostatectomy. Here, we see that about 14% of men never achieve an undetectable PSA following surgery. And we know that these patients are at significantly higher risk of developing biochemical recurrence, metastatic disease, and death. So the majority of these patients end up receiving consolidative therapy, with ADT being a significant component of that treatment as well. Among the patients that do achieve that undetectable PSA, we see that roughly 20% incidence of biochemical recurrence. And again, the majority of these patients will go on to receive salvage therapy containing androgen deprivation therapy. when we put this all together, we see that somewhere around 16% of patients with localized prostate cancer in our music registry end up receiving at least one dose of androgen deprivation therapy as part of their prostate cancer management. And we know there's a similar proportion of patients that actually present with de novo metastatic cancer. And for those patients, ADT is known as a mainstay of therapy there as well. So given this high incidence of androgen deprivation therapy use, our speakers today will talk about the potential side effects, including effects on bone health, cardiovascular concerns, issues with sexual function and mood and psychological problems, as well as the impact on body image. Our experts today are Dr. Jason Hafron and Dr. Megan Karam. Dr. Hafron is a urologist and the CMO and Director of Clinical Research at the Michigan Institute of Urology. And he's recognized nationally as an expert in the management of patients with advanced prostate cancer. Dr. Karam is a medical oncologist at Michigan Medicine with a clinical practice devoted to genitourinary oncology. And she's a health services researcher with a primary focus on quality of care for patients with advanced prostate cancer. Following their presentation, we'll have a panel discussion to address audience questions, and this panel will feature myself, Dr. Kevin Ginsberg, who's the co-director of our Music Prostate program, and Ms. Shannon Began, who is a nurse practitioner at the Karmanos Cancer Institute and routinely manages patients with androgen deprivation therapy. With this introduction, I'd like to turn it over to Dr. Jason Hafron. Dr. Hafron?
Thank you, Dr. Borza, and thank you, Music, for this opportunity to present to you tonight. I'm Jason Hafron with the Michigan Institute of Urology, and tonight I'm going to talk to you about the management of androgen deprivation therapy, or the management of ADT. Here are my disclosures. Many of you will ask, why is it important for as a urologist to be involved with the management of ADT in prostate cancer patients? But here's a study from the University of Michigan that looked at claims data in the early 2000s that showed that urologists are involved with all of the care of, or all phases of the care of a patient, from initial care to continuing care to end-of-life care. And you can see that in this slide, that the orange or salmon-colored bar represents urologists. And as you can see, based on the claims data, urologists are involved in the care of the patients, essentially from diagnosis to death. So I disagree with many urologists who say that we don't need to be involved or understand the management of ADT, because we are treating these patients. So why do we use ADT? What is it? What at a high level, what is ADT? ADT, or short-term ADT, is instrumental in men receiving radiation therapy, and also is the foundation treatment in men with advanced prostate cancer. All men who develop advanced prostate cancer will receive ADT and essentially remain on this for the remainder of their life. The objectives of my talk tonight is to review the types of ADT, understand the proper delivery of ADT, understand the complications of ADT, and then monitor and hopefully prevent some of the side effects that are associated with this treatment. Here's the androgen pathway. We are very familiar with this. This goes back probably to high school biology. But if you look at the slide on the left, is that this is essentially the types of treatment that we have available today. There's LHRH agonists, there's LHRH antagonists, and then there's the oral or novel hormonal therapies, which I really won't talk to you about tonight. But if you look at the LHRH agonists, they basically work at the hypothalamic level. They cause a surge or loss of the LHRH secretion through agonist properties and downregulation of the receptors in the pituitary, which essentially just leads to decreased LH secretion. The antagonists block the hypothalamic axis. They don't lead to a surge, and they block the LH secretion, which in turn leads to decreased testosterone throughout the body. Here's a summary of all the agonists that are commercially available today. We have leuprolide sub-Q, we have leuprolide IM, triptyline, and garcin. This slide's not meant that we have to memorize all these types. A lot of the decisions for the use of these are made by your institution. But the point of this slide is that these agents can be given sub-Q, they can be given IM, and then they have various dosing intervals from 1, 3, 4, and 6 months. Here are the antagonists. We have two antagonists that are commercially available today, degarelix and relugolix. Degarelix is monthly sub-Q injection, and our newest agent is relugolix, which is an oral agent, which leads to some interesting options for treatment using an oral option. So one of the key things and what I stress within our practice at the Michigan Institute of Urology is the importance of testing testosterone and reaching an appropriate testosterone level. These drugs are approved as testosterone suppression agents. And if you're not measuring testosterone, if you don't know the patient's testosterone, if you're not monitoring regularly, you're not really monitoring if the drug is being effective. There is some controversy on what level to achieve. If you look at Bethesda Consensus or EAU or Canadian Urological Society, they recommend a T level less than 20. If you look at the FDA requirements for drug approval is they have to meet an endpoint of less than 50. And then they have the secondary endpoint that you can achieve of less than 20, which they call profound castration. However, the AUA and the NCCN have not updated their guidelines and remains at castrate levels of less than 50. The optimal T target concentration is an ongoing subject of debate. However, in my practice, I shoot for the lowest testosterone possible, and I shoot for a testosterone concentration in the single digits. Another important thing to keep in mind when using these agents is that these have to be delivered on time. When all these studies were completed in trial, they're based on on-time delivery. We did a study where we looked at 85,000 injections in the US between community and academic urology and oncology practices. And what we found was quite disturbing is that 27% of the injections are late. You may say no big deal, but when you look at the T levels, is that you see an escape or an increase in testosterone levels where they become non-castrate levels. And here you can see on the slide is that of the late patients, 27% had breakthroughs greater than 50, 43% had breakthroughs greater than 20. I think this is very important that as you run your clinic, as you treat these patients, you work with your staff, have systems in place, that these patients get on-time treatment so that they can be treated per the label, and that you can confirm that their T suppression is being maintained. And again, regular T testing is critical when evaluating these patients. PSA alone does not really tell you what's going on and how effectively the medications you are using. However, what's most important about these medications is understanding the complications is critical to optimizing the health outcomes of these patients. We know you have to give it on time. We know we have to shoot for very low testosterones, but there are significant side effects from these medications that you as the urologist or the care provider can help mitigate. And I've broken them up into 5 domains: the cardiometabolic, bone health, sexual health, psychological, and lifestyle. These are the common domains where these medications will cause side effects. It's not that as urologists we have to manage all these, but we need to work with our primary care teams, the cancer teams involved with these patients, to make sure that these side effects are mitigated or decreased as much as possible. So let's start with cardiometabolic complications. Many of you may or may not know that androgens are protective on the cardiovascular system. They cause coronary vasodilation. They cause plaque stability. They're antiarrhythmic with QT shortening. They have a favorable effect on body composition. And in men with coronary artery disease with low T, it is a marker of increased all-cause and cardiovascular mortality. However, when we take away the testosterone, we see significant changes in our patients. We see the development of dyslipidemia. We see increases about 26% in triglycerides. We see increase in about 10% of total cholesterol. we see LDL rises, and we see HDL levels decrease. We also see worsening of obesity. We see weight gain after 1 year on ADT, which can average 1.5 to 4 kilograms. We see an increase in total body fat as well. And lastly, we see insulin resistance. ADT decreases insulin sensitivity in diabetic men within 12 months. So knowing the negative effects of loss of testosterone, it's important when you're managing these patients that you consider and you maintain the cardiac health for all of your patients. Obviously, a healthy diet is important. A diet with fruits and vegetables, less processed foods is best. It's important that you assess the cardiac health when starting a patient on ADT. Most of the cardiac complications develop within 6 months of starting ADT. Regular exercise, resistance training is important. Smoking cessation is obvious. And statin use is also recommended and should be considered. There was a recent meta-analysis in JAMA that showed the use of statins decreased all-cause mortality by 25% in prostate cancer patients and reduced prostate cancer-specific mortality by about 30%. Weight control is obviously important. And then periodic testing. You need to know the patient's blood pressure, hemoglobin A1C, blood sugar levels, and LDL levels, not as a urologist that we would treat it, but we need to make sure that they're being adequately treated by their primary care team, their cardiologist, so all these parameters are within appropriate levels and being managed appropriately as well. So the other debate that's going on or something to consider is an antagonist better for cardiovascular risk versus an agonist? The reality is the jury is still out. There's as many papers as you find that show that there's a benefit for an antagonist. There are papers and literature that shows there's a benefit for agonists. The two trials that were developed were developed to test this were actually one trial was not completely randomized, and it was didn't receive accrual to its potential, and there showed no difference. And then the most recent trial, the Replace trial, was canceled early based on interim analysis of no effect. So I think we haven't designed the appropriate trial yet. I think it's important that as you see, some notes in the literature, some post hoc analysis, that we wait for the final trial to decide if an agonist or antagonist is better for the patient to minimize cardiovascular risk. Let's talk about bone complications within ADT. Here's an important slide, and this was an eye-opening slide for me when I saw it. Here's the bone loss at 1 year for various clinical situations. If you look at a normal man, he loses 0.5% of bone mineral density per year. If you look at a menopausal woman or a perimenopausal woman, they lose bone loss at 1 to 2% per year. And this is what really shocked me and opened my eyes, is that men on ADT, a GnRH or LHRH agonist, they lose bone at 4.6% per year. And we hear a lot about osteoporosis in women. Women are very well informed. However, when you look at this data, men on ADT lose bone at 4 times the rate of a menopausal woman, something that we need to keep in mind and aggressively treat. So we're clinicians here. We're not, endocrinologists. Bone mineral density is important, but what is really happening as far as fracture risk? And here's data from a recent article that shows the fracture risk is about 20% in men receiving ADT versus 12.6% in men not receiving ADT, with a relative difference of 54%. So a significant increased risk of fractures in addition to loss of bone mineral density. The question that always comes up is how often or how many doses does this risk occur? And here's a slide, a figure from the same manuscript that shows that bone loss or fracture risk basically worsens right after that first dose. So the question always comes up, when do I have to start managing bone complications or minimizing bone complications? It's once a patient starts ADT, based on this literature and based on many other studies within the literature. And how do you manage bone health? I think you have to take a bone health history. I didn't go into urology or ever expect I would be taking a bone health history with my patients, but it becomes very important. You need to assess their personal and family history, assess their fragility and risk of fractures, their smoking history, their alcohol consumption. All patients on ADT should be supplemented with vitamin D3 and calcium. Regular exercise is extremely important, probably the most important intervention you can do with these patients, and that should involve resistance training. And then DEXA scanning and fracture scores. You need to measure what their bone density is. The common tool that we use is the DEXA scan, and that should be checked every 2 years. Like I said on the previous slide, every patient on ADT should be supplemented with vitamin D. I start off with 1,000 units, and then we'll go up. I typically also use calcium, 600 milligrams, and I monitor their vitamin D levels. Their vitamin D levels should be above 30. If they're not, we'll increase the vitamin D levels, oral supplementation appropriately. Also, if they meet criteria, anti-resorptive therapy is very important. Here are the 4 options that are most commonly used. In our practice, we commonly use denosumab. It's a sub-Q injection that's given every 6 months. Not only do we like it because it's a sub-Q injection, but it's the only FDA-approved agent for men with non-metastatic prostate cancer. And in the trial that led to the denosumab approval, you see that not only did denosumab prevent bone loss, but it actually grew a significant amount of bone. If you look at the orange line in the graph, the blue line is the placebo, that these patients had significant improvement in bone mineral density, and the relative difference was about 6.7%. So not only did they not lose bone, but they actually grew bones, making it an effective treatment for men at risk for fractures. Next, I just want to talk about sexual health. Just run through this briefly, is that sex function is inherently altered with ADT. Almost all patients will experience ED, and it's not just ED. They'll also have a decreased desire, lack of orgasm, and reduce of genital size. They'll also have body changes, gynecomastia, and weight gain that can affect sexual interactions. So managing sexual health while on ADT, I think it's important that you tell them that this will happen. It's important that you set realistic expectations at the start and encourage alternative forms of intimacy, encourage open communication with their partners. For those inclined, they can consider sexual aids. But the bottom line, to improve the quality of the erections, you're going to have to basically go to intracavernosal injections, VED, or potentially penile implants if that's appropriate with the patient. As far as the psychological, there is a psychological impact with ADT, and you need to be aware of it, that ADT increases the risk of depression and anxiety. You need to assess it at baseline and throughout treatment. Consider, if you have the resources, consider validated depression and anxiety screens. Refer for treatment as indicated. And I think the bottom line here is don't ignore the signs and symptoms of altered psychological health. If a patient appeared depressed or is developing significant anxiety, it is probably real and should be referred to the appropriate specialist for treatment and management. Lastly, let's just talk about lifestyle and behavioral health. Lifestyle, ADT is associated with increased body fat percentage, decreased lean body mass, and increased weight and BMI. With that in mind, stress the importance of aerobic activity and resistance training. Not only will aerobic and resistance training improve the body fat and try to maintain body muscle, but it also reduces overall fatigue, which unfortunately is a significant side effect of most ADT treatments. It's also important stressing exercise, and if they have the patient has the resources, refer to an exercise physiology program if available, refer to a local gym, a local trainer if possible. If the patient doesn't have the resources, I'll frequently refer them to online exercises that they can do. A lot of it is chair sitting or resistance or band training. Again, resistance training and maintenance of muscle strength is really critical. And then nutrition becomes very critical. There's some significant studies within the literature that shows nutrition is very important in advanced prostate cancer. For those on ADT, you want to maintain a low carbohydrate diet, a Mediterranean diet, a diet full of fruits, vegetables, and unprocessed protein sources. You want to avoid processed foods, the classic American diet, trans fats, simple sugars, excessive alcohols as well, can also work against you and can affect your overall survival. Seems like a lot, and it is a lot, and it seems as a urologist can be overwhelming if you're managing these patients. I was involved in a working group called the PC360 working group, where we worked with 14 different specialists, oncologists, exercise physiologists, psychologists, patient advocates, nursing, everyone involved with this care, and we developed a playbook. And what we are working on is a playbook so that these mitigation strategies are occurring in the background so that as urologists, as oncologists, we can focus on PSA, we can focus on the scans and make sure that our ancillary services, our primary care doctors, our cardiologists are all being involved in the care of these patients. As urologists, not that necessarily that we're going to be managing the side effects of ADT directly, but I strongly feel that we need to be aware of this and leading this care team so that these patients receive the appropriate care that they deserve. So in conclusion, ADT is an integral to the treatment of prostate cancer, particularly short-term ADT for radiation, as well as long-term ADT for patients with advanced prostate cancer. ADT can affect men's physical, sexual, and mental health. And lastly, careful monitoring, prevention, and treatment of side effects from ADT can help improve quality of life and overall survival of our patients on ADT.
My name is Megan Karam. I'm a medical oncologist at the University of Michigan in the Ann Arbor VA, and I'm going to talk today about androgen deprivation therapy. I have no disclosures. So first, we're going to start off with an outline. I'm going to talk about different forms of androgen deprivation therapy in the form of castration and then also other forms of androgen manipulation. We'll discuss side effects of castration and managing them, and then side effects of these other forms of androgen manipulation and how to manage those. So first of all, I know a lot of you may be familiar with androgen deprivation in general, but it's mostly gonadal androgen deprivation that most people are used to hearing about. So that comes in the form of either surgical androgen deprivation with a bilateral orchiectomy or medical, which is what we typically use gonadotropin releasing hormone analogs. These can come in the form of GnRH agonists, such as leuprolide, goserelin, triptorelin, or GnRH antagonists, including the injectable daguerreolex and the oral relugolix. Other forms of androgen manipulation that have been used more frequently lately, and these are usually in addition to castration, are androgen signaling inhibitors. They come in the form of abiraterone, as well as androgen receptor antagonists, such as enzalutamide, apalutamide, and darolutamide. So what are some side effects of androgen deprivation, specifically in the form of the castrating androgen deprivation? So when I talk to patients, I usually discuss with them what are the dangerous side effects and then what are the annoying side effects. And so first we're going to talk about the annoying side effects of androgen deprivation that could affect their quality of life. So first of all, hot flashes, mood swings, aches and pains, breast tenderness, loss of libido, erectile dysfunction, and then changes to body image, which are distressing for some men. Breast enlargement, decreased penis size, decreased testicle size, weight gain, and muscle loss. as well as body hair thinning. So let's go into a few of these in a little bit more detail. So hot flashes are very common. They affect 80% of men to some degree, some much more severe than others. So we don't always have to manage these, but management can be attempted if patients are reporting significant effects on their quality of life. So some medical options include venlafaxine, which can be typically the starting dose is 75 milligrams a day. And as gabapentin is also a reasonable option. 300 milligrams every evening is usually the dose that I start with, but this can be started at a lower dose as well. And generally, I tend to use this for men who mostly have hot flashes at night that wake them up. But for those men who have them all day long and they can tolerate gabapentin all day long, you can certainly increase the frequency to 3 times a day. And oxybutynin is questionable. It has been used in some cases. It's not totally clear if it's effective, but certainly if you try it and it works, it's worth considering. Acupuncture has been a method that has been helpful for some men. And then there's recently been something called a cooling bracelet that I've actually heard from patients has been very helpful. I think there's limited data on this, but something that patients could certainly reach out and try. Another side effect, breast tenderness, that we do have treatments for if this is severe. Prophylactic radiation to breast bed tissue can be done before breast enlargement occurs. If done after breast enlargement, it doesn't tend to help. Tamoxifen can be considered as well. And then sexual dysfunction, which occurs in almost all men who are started on androgen deprivation. So referral to therapists for sexual dysfunction for patients and their partners is very reasonable and encouraged. And then lifestyle modifications that you'll hear about later can help with lots of different things, can also help with sexual dysfunction. So increasing exercise, smoking cessation, weight loss, these can be very helpful for sexual dysfunction. And then if those things don't help or additional support is needed, certainly medications are an option. And then as urologists are well aware, there are other urologic procedures. Weight gain and muscle loss. So these are very important. Most men will gain about 10 pounds in the first year of androgen deprivation. This tends to be most pronounced in men who are already overweight and obese, but certainly can affect all men. Management for weight gain and muscle loss is careful diet and lots of exercise. So men who do exercise frequently and regularly actually can really mitigate these side effects. And exercise, I tell my patients frequently, is probably one of the best studied interventions, and one that actually has the most promising data for. So exercise. And just an example of that, here's a study from the Journal of Clinical Oncology from 2014. And they showed in this study that exercise improved muscle mass, improved mental health, strength, bone density, cardio fitness, weight loss, decreased fatigue, and also improved sexual health. So those are kind of the annoying side effects that we talked about. Now, what are some potential new medical problems that patients can encounter? Osteopenia or osteoporosis, sarcopenia, which is thinning up the muscles and muscle loss, weight gain, diabetes, cardiovascular disease, cognitive deficits, depression and anxiety, frailty, anemia, chronic kidney disease, and venous thromboembolism. Now you'll see on here that weight gain I included as an annoying side effect, but also as a potential new medical problem because it certainly can contribute to new medical issues. So how do we manage some of these things? When it comes to bone health, we know that an increased risk of osteopenia and osteoporosis can be harmful for patients. So ways that you can prophylax this, I usually recommend that patients start calcium and vitamin D supplements. Now, this can be challenging for patients who may have a history of kidney stones or constipation, where they're, being on a regular calcium supplement may not be ideal. But for whatever amount they can tolerate, it's reasonable to consider. And vitamin D, and especially if they can't have calcium, staying on vitamin D is important. Again, exercise comes up. Weight-bearing exercise, very good for bone health, walking, running, things like that. Any kind of exercise is good, but things like swimming and biking, maybe not as good for the bones. But if that's all they can do, it's better than nothing. Other things that can improve bone health, decreasing alcohol intake, smoking cessation, again, we've seen that before. And then that's how you prophylax against osteopenia, osteoporosis. But how do you monitor for this? So we recommend regular bone health assessments. So a baseline DEXA scan, which is a bone density test at the outset of starting ADT, but then also regular surveillance bone density tests every couple of years. And then there's also something called a FRAX score that I tend to use. Your DEXA scan will give you in the report section what someone's 10-year risk of hip fracture or major osteoporotic fracture is. But a FRAX score can actually help give you a little better idea of that. So this is just something that you can look up online. And then you type in the patient's age, their weight, their height, and then whether they have a family history, history of smoking, alcohol use, and then secondary osteoporosis. And I usually will check yes for secondary osteoporosis, which is a osteoporotic risk factor. That is the ADT itself. And then you can plug in their bone mineral density down into that bottom section. Let me see if I could show you here. Right here. And this will help you just better tailor what their actual risk is. If patients have a risk of hip fracture of at least 3%, then we generally, and let me just continue this. I think I have this here. If men have a risk of hip fracture of at least 3%, we generally recommend treatment with an osteoclast inhibitor, or if they have a major osteoporotic fracture risk of greater than 20%. And so that FRAX score will tell you exactly what those numbers are based on all the risk factors that you plug in. So who do we recommend treating with this? I mentioned based on the FRAX score, but also men with known osteoporosis, it would be reasonable to treat with osteoclast inhibitors. And what are the osteoclast inhibitor options? Zoledronic acid, which when we're trying to prevent osteoporosis comes in the form of Reclast. This is given once a year. And then denosumab, which in prevention of osteoporosis comes in the form of Prolia, which we give every 6 months. And then alendronate is an oral osteoclast inhibitor that can be used as well. Precautions to be aware of if your patient has osteoporosis or a high risk of fracture and you want to start one of these therapies. Generally recommend dental clearance because of the risk of osteonecrosis of the jaw. This is another reason to make sure patients are on calcium supplementation because hypocalcemia is a risk. And then I would also consider a limited duration of this. Once men are started on therapies, osteoclast inhibitor therapies, it doesn't mean they have to be on them the rest of their life because a lot of the risk factors are cumulative. So generally a few years of therapy is reasonable. This is another ASCO special article. This was done through Journal of Clinical Oncology, again, endorsing the Cancer Care Ontario guidelines for bone-targeted therapies. So what about cardiovascular disease and diabetes, which is also increased risk after starting androgen deprivation? A retrospective review, several retrospective reviews have shown the incidence of diabetes, cardiovascular disease, stroke, and cardiac events almost double with androgen deprivation. And this is with any form, surgical, like an orchiectomy, or the GnRH analogs. There is conflicting data regarding the GnRH agonist versus antagonist and the risk of major cardiovascular complications. We generally, in our practice, use GnRH agonists. I have occasionally considered an antagonist in someone with an active, severe cardiovascular condition, someone who perhaps has a daily angina where they're taking nitroglycerin constantly, or somebody who, just recently had a myocardial infarction. And if they cannot be optimized before initiating androgen deprivation. But again, the data for this is conflicting. So what about cognition and mental health? We do think, and there is some conflicting data on this as well, but we do think there could be an increased risk of dementia with androgen deprivation, increased risk of depression and anxiety. So it is reasonable if you are suspicious that somebody may have worsening memory or changes to their mental health, to keep in communication with their primary care physician, and don't hesitate to refer them to social work for any mental health concerns, as this patient population already has a higher risk of these conditions. So what are some side effects of some other forms of androgen manipulation? So one of those forms of androgen manipulation is abiraterone. Now, this is just a quick schema showing the steroid cascade. And how abiraterone works is by inhibiting these enzymes in that steroid cascade. And by doing that, aldosterone tends to be upregulated. And that's where a lot of the side effects for abiraterone comes from. So we give this along with a low dose of prednisone. Side effects of this combination can include hypertension, congestive heart failure exacerbations, hypokalemia, swelling, myalgias, sarcopenia, and then, of course, the androgen deprivation side effects that we already talked about. So how do we monitor for this? Whenever patients are started on abiraterone, I strongly recommend close monitoring of these patients at least the first couple of months. This includes regular blood pressure monitoring in their home. So I recommend all patients get a blood pressure monitor and record their blood pressures. In addition, I recommend getting laboratory tests every 2 weeks to check on their potassium and other electrolytes, as well as their liver function tests for the first few months. Some other androgen signaling inhibitors, these are the receptor inhibitors. So they include enzalutamide, apalutamide, and darolutamide. And the way that we abbreviate them sometimes is right here, ARSI, or androgen receptor signaling inhibitor. The T over there is a symbol for testosterone, and then this is androgen receptor. And then this is a prostate cancer cell. So I'm going to show you briefly how these androgen receptor signaling inhibitors work. So they first work by inhibiting the androgens from binding to the androgen receptor. They also can inhibit translocation of the receptor to the nucleus, and then the AR binding to DNA and coactivator recruitment. And all of these work pretty similarly. So what are some side effects of these therapies? Fatigue, skin changes, neuropathy, leukopenia, which is low white count, risk of seizure, cognitive deficits, other central nervous system effects like memory changes, depression, and anxiety. And then there are several drug interactions to be aware of, including some common drug interactions that they could have with some common medications such as anticoagulants and antiarrhythmics, which are pretty common for this patient population, so to be aware of. And then, of course, I can't talk about all of these oral therapies without talking about financial toxicity, which is a very real threat to a lot of our patients. So it's important to know that injectables and chemotherapy are generally covered through a different insurance benefit than the oral therapies. Out-of-pocket costs for oral therapies is highly dependent on the type of insurance coverage that a patient has. So for commercial insurance, generally there's a low direct out-of-pocket cost for patients, and this is for a number of reasons, including copay cards that some manufacturers offer patients that have commercial insurance. For Medicare Part D, unfortunately, out-of-pocket costs tend to be the highest for some patients who don't have supplements, and this used to be about as high as $10,000 a year for some people. We're hoping with the Inflation Reduction Act that this will improve, and that should be starting this year. Occasionally, patients with very high out-of-pocket costs will qualify for grants or free drug programs from manufacturers, so this is to be aware of. And of course, don't forget the VA for your veterans, which it's surprising how many people are veterans and don't get care in the VA. So keep that in mind, where veterans can actually get oral therapies for much lower costs through the VA. So take-home messages from today. Androgen deprivation therapy can seriously affect quality of life for patients and compound medical problems of aging men. Patients started on androgen deprivation or androgen receptor signaling inhibitors will need to be monitored for increased risks of cardiovascular disease, diabetes, frailty, and mental health problems, among others. Primary care may not be familiar with the side effects of androgen deprivation, abiraterone, and these other oral therapies, but primary care are the experts in managing a lot of these conditions in their general patient population. So keep them in mind. And don't forget about financial toxicity for your patients. Thank you very much.
Great. Thank you both, Dr. Hafron and Dr. Karam, for those wonderful presentations. We'll transition now to the panel discussion, and here we'll have Jason, Megan, myself, joined by Ms. Shannon Began, who is a nurse practitioner at Carmanos, who frequently manages men with ADT treatment, both in the initial setting, and I believe, Shannon, correct me if I'm wrong, you also see men who are on longer-term ADT.
Correct.
Perfect. We may or may not also have Dr. Ginsberg joining this panel. He was intended to moderate, but is running a little late in the operating room. So if you see him pop on, we may have a fifth member joining our panel.
I'm here, but I'm going to defer to you, Tudor, for running the show here. I apologize, everyone, for being late. Stuck in the operating room, but nonetheless, I've saw the recordings. I know Jason and Megan, gave terrific talks, tons of great pearls of wisdom here for making sure that we're providing the best care for our patients. So thank you both. And again, I apologize, everyone, Nationally Music members and friends of music, for being a little late.
Well, welcome, Dr. Ginsberg. This is perfectly timed. I'm glad you are could accommodate just in time finish here. So why don't we start with a couple of questions? I think one of the early ones that I saw come through was for Dr. Hafron. Jason, in terms of the timing of ADT, I know that a lot of this can sometimes be done by members of our teams and not directly by us as the urologists. Can you tell us a little bit about the process you have in place at MIU to make sure that you can provide timely ADT delivery?
So thanks, Tudor. Thanks, Kevin, for this opportunity. And thank you, Music, to be a part of this great collaborative. So many great things have come out of Music, and we're just happy to be a part of it. That being said, timing of ADT is critical. The study we did showed that most of the time we're late. Unfortunately, I don't think we have a great process at MIU, and I think it just has to deal with reality. We know if we give these agents early, they won't be covered by insurance, so we always have to give them plus 1 day when they're intended. And then the reality is, it may come on a weekend, it may come on a holiday. Patient might not be able to get back to the office that day. So we don't have a great system. I think we stress to our staff that we want to get them in close to on time as possible, but never early. But this paper was just kind of a awakening to all of us that we got to work on this and do better.
Great. I think that's really important. When we have the sort of our own systems limitations in terms of how we can deliver this care, and then superimpose the financial restraints from our payers, that makes this quite challenging. So I think one thing perhaps we can kind of take away as a longer term goal is trying to identify some best practices here to make sure that we are giving this medicine as timely a fashion as possible to really maintain that castrate level androgen blockade. We've got a couple of questions coming up in the chat here. There's a couple that relate to hot flashes. Perhaps Dr. Karam, you may be able to provide some insight here. So Dr. Lane asks, what about using Megace for hot flashes?
So Megace for hot flashes, I think is it's actually very effective, but I think there's always a concern with Megace. Other side effects that it can contribute to, such as weight gain. There's also risk of thromboembolic disease, and then there's also like a potential hormonal implication with Megace. So I have occasionally used that as a last resort. I might have like one or two patients I've ever used it in. But usually I try to avoid it and use the other ones instead.
Great. And on that, in that vein, Dr. Mansour asks, what about Veozah in the use of hot flash mitigation? He's aware that it's approved currently for women with vasomotor symptoms. Is this something on the horizon in our ADT population?
Well, I think, Tudor, we got to be careful here because the label is for menopausal women. There is no published literature right now in men, and especially men on ADT. So that would be completely off label. So it's appealing, but it's not, it's again, completely off label.
Are we aware of any studies being done on this medication in men on ADT? Is that something that we should expect, or is this entirely on sort of new territory?
We've reached out to them to try to do some investigator-initiated trials, and there wasn't a lot of interest. I think this was early at launch, but it's kind of interesting. All of a sudden, I've seen sample boxes show up in my office. So I think I haven't used it on these patients. Again, it's off-label, but I think it would be a great. This is a significant problem. This is the number one complaint. This is what the patients hate. And they're, kind of like what Megan was saying, there is no really great treatments. I'll frequently just tell patients, just tell them you're going to get hot flashes. It's part of the treatment. Reassure them, set the appropriate level of expectation. And, they say, well, what can I do? And I literally tell them, you just get a fan, put a fan in your room at night, things like that, which is kind of embarrassing, low quality medicine, but that's kind of reality right now.
I think that's an important thing to acknowledge here. We know there are many side effects. Some we need to monitor for, some we can intervene for, and others we just need to have appropriate expectation setting so that our patients understand what is expected here. I think that's another way that we can provide quality care is just appropriate education, even if we don't have a great answer for some of these side effects. I'll direct the next question at Ms. Began. Shannon, you're on the front line. You see lots of these men. Tell us how you think about bone health and kind of what's your go-to for in terms of prescriptions or management for these men?
For bone health, we do have patients on calcium and vitamin D. It's beneficial to have a baseline scan before they start ADT or within the first 3 months, but that doesn't always happen. If we suspect someone is more prone to osteopenia, we do a DEXA scan, and then here we do Prolia.
Can I ask a follow-up question to both Jason and Megan? And that is, you showed that the osteoporosis, the bone weakening is actually relatively soon. You said, those very nice Kaplan-Meier curves, that anyone who gets a dose is at risk. They have some weakening. So should all these men be getting DEXA scans, or can we, just kind of the long term, the 2 years or the 3 years, or should we really be getting and pushing that baseline DEXA scan even for the short term, the 4 to 6 months with the unfavorable intermediate risk?
Yeah, in our practice, we do. I think it's important. I think fractures is a significant risk in this patient population. And then you throw in falls with that. If you look at men over 65 or elderly patients, falls is the sixth leading cause of death. So I think we are obligated to aggressively evaluate it and aggressively treat it. Every patient should be on vitamin D, calcium. You try to get a DEXA, and if you can't get a DEXA, get a Frax. And, really talk to them about exercise, resistance training. I mean, I think a lot of this with good pathways and good, support, a lot of these complications can be minimized. We all know we've seen our patients develop a hip fracture or break an arm just from a simple fall, a standing fall. A lot of that can be avoided or minimized. And I think it's a responsibility of us as, if we're going to prescribe these medicines, that we have to really focus and have a solid pathway here. At MIU, we've made this a mid-level disease. We have virtual bone health clinics. All our patients on ADT have to be evaluated by one of our mid-levels. They get the DEXA scan, the Frax, they get the vitamin D, calcium supplementation. And then if they meet criteria, they'll get, denosumab every 6 months. So I'm curious to hear what Megan thinks, but we treat it very aggressively and take it very seriously.
Yeah, I agree. It's encouraging to hear that you guys are doing that and have a clinic dedicated to it, because I think even among medical oncologists, not everybody pays as much attention to bone health. We're so focused on treating the cancer, we forget about all the problems that we can contribute to. So I think that's great. I think it's always a balance because our treatments have a lot of, just like our androgen deprivation can cause problems, so can our bone modifiers. So I think it's especially important for your patients who, they have pretty minimal prostate cancer, but they still may benefit from ADT, but they're probably going to be on it for 10 years. They may not actually do well with osteoclast inhibitor for 10 years. They may end up getting osteonecrosis of the jaw, or atypical fractures in their hip or something like that. So I think it's always a balance. We do DEXA scans, and only recently I've been kind of reevaluating, how long do patients actually need to be on these agents? Are we still, can you stop after a few years? So I think the jury's still out on that too. So working with endocrinology, potentially, if you have a question about somebody, working with primary care, and then just always reevaluating. So, how are they doing with all these side effects?
No, Megan, I think that's a good point too. And a common mistake that we see is you stop the ADT, whether it's, 2 years of ADT, patient has diagnosed osteoporosis, you really shouldn't stop their treatment for their osteoporosis just because you stop the ADT. They still have to be followed. The osteoporosis doesn't just go away because you stop the ADT. And I think that you got to still manage them, even if they're off their ADT, and manage their osteoporosis appropriately.
Yeah, but also to be aware of the, potential long-term effects of managing the osteoporosis too. So I think I think this is also, the data is not great here, but there is a risk when you, for those men who, Prolia is great and denosumab is a great drug, but there's a risk of rebound fractures if you do stop.
Yeah.
And so kind of being aware of that, and sometimes doing a dose of zoledronic acid if you do decide to stop, to kind of like seal it off, I think is recommended. But again, I think just seeing if the benefits are outweighing the risks.
It seems like sometimes the simplest things are the most effective. Weight loss and exercise. Both you really hammered on that point. And Megan listed off point after point after point of sexual health gets better, bone health gets better, mood gets better, depressive symptoms get better. Is there any particular exercise, any tips? The first step is certainly the hardest, just getting them to do something. Do you have any kind of go-tos that you bring to your patients to kind of help get them onto an exercise program?
I've found what is as effective as just telling them. I think that stressing the importance and letting them know how important it is. so that they sense that you're serious about it. I think that's the first. But let's be realistic here. These are elderly men with, usually multiple comorbidities. They're not going to be going to like LA Fitness and, sitting on a bench press or squatting, large weight. So what I found effective.
I just wanted to be clear. I'm not going to go to LA Fitness and start bench pressing and squatting large weight either. Just
but
to level the playing field here.
So then maybe I can send you some of these videos, but we have online videos where they can watch, a lot of resistance training, a lot of bands, like the rubber bands. We have 15-minute exercise videos that they can watch and do. A lot of like isometric exercises. I call them chair exercises, where they'll sit in a chair and they can do a whole circuit of exercises, because at the end of the day, what you really want is that leg strength. You want that core strength. So that they have balance. Again, the biggest fear with these guys is a fall, or one of the fears is a fall. So anything you can do to build core and leg strength is really critical.
Yeah, I couldn't agree more. I think I've used a few things with patients. I think motivation is important, and for some reason, everyone has a major fear of the C word. And so I will tell them cancer hates exercise. And, if I could, if there's anything I can tell you lifestyle wise that's anti-cancer that you could do, it's exercise. So that somehow has motivated a few of my patients, even though when you tell them it's going to help your fatigue, it's going to help your cardiovascular health, all this, like that just goes in one ear and out the other sometimes. But telling them that it's going to help fight their cancer, I think is very motivating. And then also, I have had a few elderly men who it is really difficult for them to just sit down and do exercises. So I refer them to physical therapy. And then I'll do that for deconditioning and debility. And then once they have, I don't know how much Medicare covers, maybe 3 or 4 weeks of physical therapy. And then that kind of like at least starts them off. And then if I've actually done that for a few times in the same patient, where they'll go to physical therapy and then they're doing great. And then maybe a year later, they're starting to go downhill again. I'll refer them back to physical therapy. So I think taking advantage of that helps as well.
Yeah, I think those are all wonderful points. Sort of stressing this as incorporating it into your routine. Like, this is no longer something that's a choice because we have you on these medications. This needs to be part of your routine. And so stressing the importance of incorporating this exercise into their daily routine, and making it feel like you eat breakfast, you exercise, you brush your teeth, that these are the things you do in the morning, or whatever will work for that patient. I think is really important to hammer home in terms of that patient education to mitigate the side effects. Shannon, one thing I wanted to ask you specifically is, we talk about managing a lot of these complications ourselves, but I know for a lot, we coordinate with other members of the care team. So, right, for cardiovascular health, the mental health issues that might arise, we're always coordinating with members of the care team. Can you tell me a little bit what that actually looks like in practice for you? How you have these conversations with patients, and then how you actually do that care coordination, within your system, and then perhaps outside of your system. I imagine most of your patients are having their primary providers not within Carmanos.
Correct. The hypertension, diabetes is usually managed by their PCP, or if they have a cardiologist. We're a lot of times seeing patients come in and their blood pressure is still uncontrolled, even though they're on hypertension medications. And then we refer them back to their PCP for better management. And then I know a lot of patients are on aspirin, which I think is something good to be on if you're at risk and you're already on ADT.
Great. We have a question from Dr. Lane here, and I'll direct this to the whole group, but I think perhaps our surgeons may have the most experience with this. So, for our men who have clearly going to be destined for long-term ADT, our men with metastatic disease, that we know this will be a staple of their ongoing treatment. What is the current sort of landscape of use of bilateral orchiectomy? Dr. Karen brought up the financial toxicity. This is a very inexpensive way to achieve this. Do we have a sense of how we're doing in terms of rates, maybe patient perceptions of these?
I think the rate is
general thoughts.
Yeah, I think the rate is pretty limited. I want to say it's low single digits when you look at it when it's ever been looked at. I think there's significant psychological effects associated with this. And also, I think you can drive down with some of these newer agents, you can drive the testosterone lower. I've honestly, I can't think of the last time I ever did an orchiectomy. I know in our resident clinic, it does come up if there's some psychosocial issues. Patient is, not going to, be involved with his care. But I don't think there's much of a role of an orchiectomy today.
I actually agree with a lot of that. I think that there's a very big psychological component to a lot of it where, yes, men will have genital atrophy and the testicles will shrink with ADT. But there's, I think it's another bridge to then do a bilateral orchiectomy and actually remove the testicles. I think that a lot of men did that. That is just, I think something that really impacts their mental health and their quality of life. Along these lines, though, could I add a follow-up to then ask about Orgovyx? And we brought up financial toxicity. Maybe Shannon, could you speak to your experience using Orgovyx? Is there a particular patient that you really think would be great for Orgovyx that you look at and you're like, oh man, they had an MI recently. I think this is someone that even though the data may not be there, as Jason said, that this is someone that you select for Orgovyx or how you make that decision?
Currently don't have any patients on Orgovyx. There was a couple patients we contemplated doing Orgovyx because of they were a little bit more high risk, but after talking to them, the patient wanted to do Lupron. So on the surgical urology side, we don't have anyone on Orgovyx.
So Kevin, we were involved with the HERO trial. We were a site. We started using a lot of Orgovyx this year because of the Inflation Reduction Act that Megan mentioned, because now of the donut is smaller for these patients. And if they're on an oral NHT, we'll use Orgovyx in combination because we can save money on their Part B copay. I think Orgovyx is a very interesting drug. I think the MACE, there's a 3.4% reduction in MACE that they saw, but that was a post-hoc analysis that wasn't powered. The thing I really love about Orgovyx is the on and the off. There's pretty fast suppression of testosterone and pretty significant suppression when you compare it to the leuprolides. It may even be superior, but they didn't get that on their label. But also they did an extension trial from the HERO where they looked at recovery of testosterone, and the recovery of testosterone is pretty impressive. So that when you use it for short-term ADT for radiation, I think it's a nice option because the guys recover really fast, and the recovery rate's great.
Megan, what are your thoughts on that in the VA system? Right, you're in a pseudo-capitated practice environment. What does that look like for you?
I feel like I see the benefit to Orgovyx, with Jason mentioned, with the rapid recovery of testosterone. So if you need a patient to have a rapid recovery, or you're on the other hand apprehensive about starting them on ADT at all, and you want to see how they're going to do, I think that would be reasonable. In the past, what I've done in people I'm apprehensive about or I want a rapid recovery is I'll use the monthly injections instead of the 3-month and 6-month injections. So I think I could see this in a similar vein. With my working at the VA and then also my interest in financial toxicity to the patient, but also thinking about this on the whole and financial toxicity as a country, having people on Orgovyx or Relugolix, for years and years and years, I think is a concern when we have a very inexpensive option that works just as well. So I guess in metastatic patients, I don't even consider it, but I could see the appeal in people that are getting like short-term ADT.
That actually is a very good lead-in into Dr. Ghani's question. So he's wondering, like you mentioned the high cost of these drugs. I think we always perhaps underappreciate what that means. Could you put a number to what the high cost actually means for a patient? Like, what does that look like? I mean, you can use the VA or if you sort of know outside VA numbers, like what does that actually look like? And then there'll be a follow-up question I'll ask you. I'll let you answer that one first.
So, and I think you're getting at like the cost of the drug itself, like that kind of financial toxicity.
Correct.
So, I mean, it's at the VA, it's very different than it is at the U. At the VA, patients' oral therapies are treated just like their statin or their metformin or their aspirin. It's like exactly the same copay. So that's so the VA is a very different situation, and their injections are, fully covered. When it comes to the U, it really depends on your insurance benefit. But, I think the sticker price of, last I looked, the sticker price of, all of our oral therapies, there's nothing less than $10,000 unless it's generic. And that's $10,000 a month. Now, that is not directly seen by the patient. Generally, the patients in January, February, if they have Medicare or insurance benefit that starts over at the first of the year, so they'll pay their biggest out-of-pocket cost at the beginning of the year. So that's anywhere between like even a couple $1,000s in one sitting. That's how it used to be, and then that would decrease to about $500, $400 to $500 a month for each patient. Now that's going to change with the Inflation Reduction Act, thankfully. However, that doesn't mean the sticker price of the drug is changing. It just means the financial toxicity that's seen by the patient is going to change. But someone still has to cover that spread of costs. So the patient may only have a few $100s a month, but the rest of that $8,000 is going to be covered by Medicare. So someone's going to be paying for that. But I think we're moving in the right direction as far as how much patients are having to see, which is great. Does that answer your question? Were you thinking about patients?
Yeah, I think that's perfect. I know that we can have you give an entire 2-hour lecture on financial toxicity and the complexities of everything that goes into that. But I think specifically for this, that's a perfect answer. Jason, you were nodding along there. I know this is something you're really aware of. Tell me in your practice what these conversations look like with your patients.
Yeah, so I mean, obviously we're in a community practice. We have a large patient population, and most of the time these are covered. I mean, I think Megan's point is valid. There's a financial toxicity of the patient, which is minimal. I'll be honest with you. We rarely have a coverage issue getting a patient the drug. And there's all these foundations or grants open where we can usually get these drugs covered for the patient. But to Megan's point is, if you look at from a large scale macro political, geopolitical level, this is a major cost to the system. I don't, looking at the system costs, I don't really focus there. I just, focus at the patient level. And these patients, somehow with all the nuances to drug reimbursement, really see little financial toxicity to themselves for the most part.
Jason, this is actually the second part of Kershigai's question. Can you tell us a little bit, like the foundations? Can you articulate like more granularly who do you work with there? What does that look like? Who does that in your office? And perhaps Shannon, you can weigh in on this from your perspective. Like, how do we get these tools to the patients in actual practice?
So I think there's these are specialty drugs, and the specialty drug market is different than what we're used to. I tell that you can't get these drugs at Walgreens or CVS. You can't write a script and the patient goes and picks it up. You have to go through these specialty pharmacies, which is a network of pharmacies that contract with the payers. And based on the payer's coverage and their contracting, it gets very complicated. I wish 60 Minutes would do a piece on this, because there's a lot of suspicious activity, in my opinion. But that being said, we have in our practice 2 full-time people that will look for these foundations, and these foundations will periodically open. The foundations are funded by, I believe, pharma, and they will open and offer a supplemental, copay assistance. And the copay assistance in some situations can be significant. And the way that our system's upside down is you can get abiraterone through Mark Cuban's Cost Plus or whatever his pharmacy is for $120 a month. Literally $120 a month. A year or two ago, this was close to $10,000 a month. But the problem is that for some people, that $120 can be too much, and that doesn't apply to your donut hole, and you can't get any patient assistance. So sometimes that doesn't even work. So I think this is the specialty networks, or the specialty pharmacy network is almost a broken system. But we think this is a lot. Megan works in oncology. I mean, this is just the tip of the iceberg. I mean, the oral medications and the cost of these oral medications throughout oncology is mind blowing. But to get back to your question, we literally have 2 full-time people that are constantly looking at these foundations, where they literally, I think I don't know exactly, but they go online, the foundations open for literally an hour or 2 hours randomly. It's unannounced. And then you got to scramble to provide to this foundation, the patient information, and then they get approved. And then the foundation closes, and no one knows when they reopen again. It's crazy.
Certainly a lot of complexity. Shannon, did you have particular experiences? How do you leverage your internal infrastructure for this? When you don't have the power to hire your own people?
We have our own specialty pharmacy, so those drugs get prescribed to the specialty pharmacy. And if there's an issue with payment, sometimes I will get something from specialty pharmacy to fill out paperwork for the patient, and I believe it goes straight sometimes to the drug company for a payment.
Yeah, so that's where it gets interesting, because I bet hospitals or large health systems can own their own specialty pharmacy, and they contract with the payers. Obviously, we're a community practice. We don't, but it's a very complicated system.
It is, and actually, sometimes I'm shocked where our pharmacy will run a medicine through insurance, and it's ungodly expensive, and they'll say, well, because we're an NIH Comprehensive Cancer Center, we have some grant to offset something. If we do cash pay for this, it's $3. Like, these real weird situations like that seem to pop up from time to time. And you're right, Jason. It is certainly too complex for us mere mortals to understand.
Great. I think we're coming to the end of our time here. I appreciate everyone being on. Do the panelists have any parting thoughts they want to share? If not, I can wrap it up.
Can I ask one more question?
You may ask another question, Dr.
Being late and then asking questions, making everyone else.
We love that student.
I want to know about diet. All right. We know from Protect, more men die from cardiovascular disease than anything else with prostate cancer, regardless of whatever arm they were randomized to in Protect. So clearly, cardiovascular health, diet, very important. Is there any particular diet that all 3 of you point anyone to? Or is there any sort of good take-home points that we could give patients in terms of diet?
Mediterranean diet. It's a Mediterranean diet: fruits, vegetables, chicken, fish, no fried food, no fast food, red meat, and pizza on special occasions.
For what it's worth, Tutor, when I said all 3, I was talking to not you and me. I was talking to Shannon, Megan, and Jason. But you, all 4 of you, then.
I was going to say, I'll put a plug. We literally had an amazing talk in our grand rounds by one of our endocrinologists exactly on sort of nutrition in general. And this came up. And so I think, one, don't be afraid to involve your colleagues. we have nutritionists and dietitians who are part of our care teams, so let's use them. But the just overwhelming takeaway was Mediterranean diet is the answer to any diet question, and then there are some unique circumstances if necessary.
Yeah.
Oh, sorry, Megan.
Sorry, I was going to say there's not like a magic anti-cancer diet, but the Mediterranean diet, I agree, is good for everything. Just like we saw that slide that had like better sexual health, better mental health, better cardiovascular fitness, all of that with exercise. The same thing goes for the diet, the Mediterranean diet. All of that will improve with a good diet.
I was going to agree with the Mediterranean diet and just improving weight, blood pressure, insulin, blood glucose.
Great. I think that's a great place to leave it here. I think we had a wonderful discussion. Again, androgen deprivation therapy is common. So many of our patients are getting this, whether it's part of primary treatment or in the secondary, biochemically recurrent or late on in the metastatic space where those patients are still coming back to the urologist for management of other problems that they may have at that time. And so we see patients on ADT. This is part of our standard practice. I'll highlight just a few things. Dr. Heffron, brought up that the timing matters. And so, our goal is to get castrate levels of testosterone suppression. And so the timing matters, and then checking the testosterone if we're worried that our timing is off to confirm that our men are still castrate while we're managing them. From a cardiovascular perspective, both Dr. Heffron and Karen brought this up. Many things can happen. Testosterone is protective, and when we take that away, there are many adverse events. These can happen as early as 6 months, and the longer someone is on ADT, the more these grow, and the more that these serious secondary complications can arise. It's important for us to be mindful of those things, and then coordinating with our primary care teams or other specialists to manage the potential complications that arise here. In terms of bone health, this is sort of the other big category of complications after cardiovascular. These things, significant bone loss happens early. We saw that slide that happens as early as that first dose, and the longer someone's on, the more pronounced it is. It's important to check this. And again, we want to avoid those potential fractures that can be very devastating in an elderly man. The treatment for this can be as simple as calcium and vitamin D supplementation, and certainly be escalated from there. But it seems like, as with many things that we discussed, exercise helps, and so getting men in that routine of having a weight-bearing exercise regimen, both for bone health and then for the many body image issues that arise, the weight gain, the muscle loss, all of these can be offset, as Dr. Karam's slide showed, by having a regular exercise regimen. Sexual health is complex in this population. We know that there are multifactorial problems that contribute to this. And so it's important to understand that oral therapy may not and often is not enough here. We can leverage our knowledge as urologists to offer additional approaches to erectile function, and then having a low threshold to involve a sexual therapist, both for the benefit of the patient as well as the partner. In terms of some common side effects, both in short term and long term, we saw from the panel discussion, hot flashes are really common. They're really significant in terms of one of those nuisance side effects. We have some medications that work, either venlafaxine or gabapentin for that right patient, as well as non-pharmacological treatments like acupuncture and cooling bracelets. But perhaps an important thing there is to just educate our patients and sort of explain that this is an inherent part of the management of their disease. And lastly, I think we hit on the financial toxicity part a lot at the end of our panel discussion. There are both individual patient issues and it was great to hear some of the loopholes that we have to sort of lower that cost for the individual patient. And then from a systems perspective, this is where our stewardship matters, right? We should offer the best treatment we can in the most cost-effective way. That's that value proposition, right? And we as urologists just need to acknowledge that in our daily practice, and especially when we're talking about medicines that cost $10,000 a month. I really want to thank everyone for participating. I want to thank everyone for joining online, both within music and outside. And let you all know that these slides will be uploaded to the music website very shortly. And so you may refresh yourselves whenever you see one of these patients in clinic. And with that, I want to say thank you and good night to everybody.